Okay, we are going to be live. I am here. Thank you. Welcome to the AAC in the Cloud. I'm here to present Donnie. The presentation is Ensuring Equitable Access to the Healthcare for AAC Users. Take it away.
Hi, so today I'll be presenting on ensuring equitable access to healthcare for AAC users. My name is Donnie Denome. My pronouns are they, them, theirs. I'm a young white person with light brown hair that's shaved on the sides, and I'm wearing a blue dress with sea turtles on it. And I'm on Twitter at GoSuperDonnie. A little bit about my background. I graduated this past May with my master's in public health with a focus in health promotion and education for people with intellectual and developmental disabilities and AAC users. I am an AAC user myself. I use a mixture of text and symbol-based AAC on a high-tech device as well as various light-tech and no-tech options. I am an autistic brain injury survivor who presently lives with my boyfriend, who is also an AAC user. I have previously worked with the Autistic Self-Advocacy Network, or ASAN, the Self-Advocacy Resource and Technical Assistance Center, or SARTAC, and Communication First. I have no conflicts of interest to declare. I may also be joined by a co-presenter, Evie the cat. My boyfriend is trying to keep her entertained, so hopefully she won't be too involved. But if you see a big ball of light brown fluff, that's her. Now I'd like to talk about the learning objectives for this session. They're up on the screen, but I'll go through them quickly. By the end of the session, you should be able to first identify barriers AAC users face in accessing healthcare. Then, you should be able to explain how these barriers cause worse health outcomes for AAC users. After that, you should be able to identify strategies for ensuring the safety, autonomy, and self-determination of AAC users in healthcare. And finally, these last two kind of go together. You should be able to apply these strategies to your own practices and work in order to better advocate for health equity for AAC users and work with AAC users to ensure autonomy. In the context of those learning objectives, I want to say that while this is a presentation mostly geared towards professional supporters, anyone can watch and learn from it. Let's talk about this problem in more detail. We know that disabled people is a group, and this is all disabled people, not just AAC users, receive lower quality health care and have worse health outcomes than non-disabled people. We're more likely to not get certain types of preventative health care, like certain types of screenings. Our health is often worse in ways that are not directly associated with our disabilities. For example, a wheelchair user who has significant tooth decay because none of the dentists near them have accessible office spaces. We are also more likely to live in poverty due to both not being able to work full-time and or receiving disability benefits that require us to live below the poverty line. And so much of the time, healthcare providers assume that we are not capable of making medical decisions, or that our disabilities mean we don't need certain types of medical care. For example, people with developmental and intellectual disabilities are much less likely to receive comprehensive sex education and sexual and reproductive health care than our non-disabled peers, because healthcare providers wrongly assume we are incapable of or uninterested in sexual and intimate relationships. Now to talk about AAC users specifically. There is little data specifically on healthcare disparities among AAC users, but what there is indicates similar issues to those faced by other disabled people. A study by Stransky et al. In the Journal of General Internal Medicine found that adults with communication disabilities were more likely to have other chronic conditions and report poor health than adults who did not. They also found that adults with communication disabilities were more likely to have difficulty accessing health care, such as trouble finding a usual source of care, and were more likely to put off or forego health care. It's important to note that AAC users may have other disabilities beyond having limited or no speech. We may have many different specialists we are seeing who we need to coordinate accommodations with. When I talk about patient-provider communication and difficulties AAC users have accessing healthcare, I want you to remember that it's not just one or two doctors who are seeing for many of us. We're facing all these different barriers to care, and we're facing them for 5, 10, however many different providers we have to see. And one more thing. Our health disparities are not inherent to our disability. Just like the example I gave earlier, a wheelchair user who has tooth decay because they can't find an accessible dentist. AAC users have poorer health outcomes that are not caused solely by our disabilities. Or we may have health problems that are somewhat caused by our disabilities, but are made worse when we can't find care. If I have an anxiety disorder that I'm not getting treated effectively because I can't find a psychiatrist and a therapist who will accommodate my needs as an AAC user during an appointment, that's a disparity. We can't just say, well, this person has a disability, of course they have worse health. That's blaming people for health disparities that aren't their fault, and oftentimes they have no control over no matter how hard they try. I'm going to go through some barriers to care that AAC users face. It's important to remember that while every AAC user has not, and maybe will not, face all of these in getting care, we are aware they exist. The threat of mistreatment, the threat of abuse, the threat of having our communication taken away from us. These are things that make us less likely to seek care because of the unknowns. I also want to add that this is not a comprehensive list. The first two are that making appointments is inaccessible and that there is no easy or accessible process for requesting accommodations. If you need to call to make an appointment, that's an access barrier for a lot of AAC users. Not all of us can use a TTY or relay system easily. Not all of us have access to someone who can make voice calls for us. And even if you can get an appointment, Trying to let the provider know you use AAC beforehand can be tricky. My old doctor's office had an online form to request accommodations, but even when I filled it out, nobody at the office ever seemed to read it. Or the process may be to message the provider ahead of the appointment on your patient portal to tell them. That's fine, but it doesn't necessarily ensure that everyone on the care team will read it. One of my constant issues with healthcare is trying to let front office staff know that I can't use a phone easily. I've yet to find a way to do this that, ironically, doesn't involve making phone calls. And then you get to the appointment and oftentimes, there are so many assumptions about how you communicate. So many healthcare providers seem to believe that every AAC user knows sign language, which is not the case. Some of us do know sign language. Some of us do use it as our primary language, but it is not universal. But it's assumptions like that we need a sign language interpreter, that we all are deaf or hard of hearing, that we do not know how best we communicate. Appointments are not long enough. They're not long enough for anyone, but they're certainly not long enough for AAC users. We take more time to communicate, almost universally, than speaking people do. Many of us have additional disabilities that mean we take longer to process information and formulate a response. If we take too long to compose a message, we're seen as not being able to decide or not knowing what we want. We can be rushed into decisions we don't want to make, and we can be forced to forego asking necessary questions because there isn't enough time. And far too often, we are denied our devices, supporters, and methods of communication. Sometimes this is necessary. You cannot take an iPad into an MRI for safety reasons. But sometimes this is a barely concealed attempt at denying us communication for being different. I have had far too many friends denied their communication devices while locked in psych wards. The reason given is usually privacy around electronic devices. But this does not take away from the fact that these policies target AAC users far more than they do speaking people, or that, curiously, they only ever seem to apply to psych wards. But the point remains, our devices and supports are taken away, almost always for no good reason. Would you, a speaking person, go to a hospital if seeking care meant they would duct tape your mouth shut? And finally, there is a lack of accessible follow-up. If my test results are only available over the phone, that's not accessible. If I'm referred to a specialist who isn't told I'm an AAC user, and I don't know that they don't know, that's inaccessible. We don't stop being AAC users after one appointment. Here are a few myths about AAC users in healthcare. These are things that some healthcare providers believe about at least some AAC users. Not all healthcare providers, not all AAC users, but these beliefs are especially prevalent towards AAC users with intellectual and developmental disabilities. And these are some of the beliefs. This is not a comprehensive list. that prevent AAC users from seeking care. Myth 1. AAC users are not capable of consenting to care. Yes, obviously, some AAC users are not capable of consenting to care on account of age, and some have been deemed by a court to be incapable of consenting to care and placed under guardianship. I will not get into the ethics of guardianship here, but suffice it to say that even if someone needs significant help making decisions, taking away their ability to consent to care is not the answer. But the belief that AAC users are incapable of consenting, or that we all have guardians, merely based on AAC use is wrong. It is laughably wrong, and it especially targets AAC users who need support with decision making. Myth 2. AAC users are not capable of accessing care on their own or without a support person. This one is tricky. Some AAC users need a support person at appointments. Some of us can get by on our own, but strongly prefer a support person. But again, the belief that AAC use renders someone incapable of attending appointments alone is wrong. It also reduces the complexities of the many reasons why someone might need or prefer a support person down to you can't communicate typically, so of course you need a support person. That isn't true. AAC users, whether we need, prefer, or go without a support person, have complex reasons for our decisions and deserve to have those reasons heard and respected. Myth 3. AAC users can't understand or follow through with instructions for care. Yes, someone may need help understanding or following through with instructions for care. Someone may need simple language or picture supports to understand instructions. Those are all perfectly valid reasons to need more help. But this myth isn't about someone needing extra help with instructions. It's about assuming that people can't understand instructions at all and entrusting our care to someone else who's seen as capable. Even if we need more support, we still have a right to be involved in our own care and have a right to receive accommodations that allow us to be involved. Myth 4. Apologies that this one is a little US-centric. If you're not in the US, I encourage you to look up whether relay services in your country are compliant with relevant health privacy laws. But anyway, there's this weird, pernicious belief in the US that TTY and other telephone relay services for deaf, hard of hearing, and speech-disabled people are not compliant with HIPAA, which is the main law about health information privacy in the US. This is not true. There have been government statements for nearly 2 decades now saying relay services, including but not limited to TTY, IP relay, video relay, and speech-to-speech, are HIPAA compliant. But this myth continues, and it makes phone calls, which are already excruciating for many AAC users, even harder when healthcare professionals insist they can't talk to us via relay. Let's talk about presuming competence. To start, AAC users are experts in our own bodies and minds. In a lot of cases, we are more of the experts on our bodies and minds than the clinician treating us. Many of us have conditions that are barely covered in medical school and other healthcare professional training. I am not saying this to negate the expertise of healthcare professionals, but to assert that AAC users are not passive patients. We are experts in our own bodies and minds, and we need to be included fully in our own care. The next point is that communication is a matter of the right supports. To give a non-AAC example, if you are trying to wish your friend who lives on the other side of the country a happy birthday, you aren't going to be able to do it face-to-face in person. So what supports your communication, enables you to communicate with them? Maybe you send them an email or a text. Maybe you call them. Maybe you have a video call. But there is something there to enable, to mediate that conversation. And it's the same with AAC users. We need the right supports. There's this pervasive myth, we talked about it in the last slide, that AAC users can't communicate or make decisions because we can't speak verbally. Even someone who needs substantial supports, for example, someone with locked-in syndrome who communicates via an eye gaze, can still communicate and can still make decisions. I assume basically everyone here is going to agree with that. But the problem is that a lot of healthcare providers won't. And when AAC users try to assert ourselves, we hit this wall where we're automatically discounted. Like everyone else, we might need support and decision making, but that doesn't mean we can't make decisions. There are so many reasons, most of which aren't unique to AAC users, why someone would need support making a medical decision. Maybe the treatment they're thinking of costs a lot of money. Maybe it would require them to take time off work. Maybe they don't understand all the parts of it and need someone to explain. Maybe they're just overwhelmed by the thought of needing care. And yes, maybe there are communication differences or barriers to them explaining what they need and want. But someone needing help is not proof of incompetence. It is not a reason to take away someone's right to a say in their own care. When I say communication breakdowns, I mean anything that prevents two people from communicating. This is not unique to AAC users. But these can be things like a device malfunction, someone not understanding our gestures, a sign language interpreter not being available, etc. The answer to someone not being able to communicate is not to take away their right to communicate their wishes. It is to empower them to communicate. A lot of AAC users, I would say most of us, have medical trauma. It's often, but not always, related to our AACUs. And a lot of this trauma centers around the removal of autonomy and other people making decisions for us. I want to give you a personal example of this. I spent basically all my childhood seeing different neurologists, psychiatrists, therapists, various brain professionals, to put it casually. And a lot of this ended up being you have this appointment on this day at this time. You're going to go to it. And we can debate the best way to handle a situation when you have a young child who needs to go to a medical appointment they don't want to, because I did need to be seeing those providers, even if I didn't want to. But one thing I didn't have for a lot of those appointments was an explanation of why. Why I needed to go to this appointment, why my parents thought it best, why I was taking this medication, etc. There's an enormous lack of power for a kid in that situation. And when you're not told why this care is important, it makes it even worse. Because you must go to these appointments, you don't know why, and nobody will explain. When I got old enough that my parents didn't have to go in with me, when they would drive me to appointments and then wait in the car, I did a lot of running away and hiding in the bathroom for the appointment. Because that was the only control I had over the situation. And when so many decisions get made for you, you'll take any chance to have a little bit of control. I say this because I want to illustrate what it's like to be a disabled person, and especially a disabled child, who doesn't get a say in their own care. And yes, there will always be scenarios where no isn't really an option, where care is urgent, or where foregoing care will be deadly. But it is traumatic to have your care decided for you, to not have a say in it, to not even really know why you need that care, or why people have made certain decisions for you. And it certainly doesn't prepare you well to be an adult, to have to make all your decisions, to be faced with medical choices and not have any experience knowing what to do. I'm in a situation right now where for the first time in my life, I'm having to find new mental health providers because I have recently moved and it is overwhelming to the point of meltdown. No wonder so many disabled adults end up in situations where they are declared incompetent and have a guardian appointed to make medical decisions for them. It's not because of any inherent defect in disabled adults. It's because we're not taught medical self-advocacy and decision-making as children, and then when we struggle in totally reasonable ways, people think we're incapable of making decisions. This is a slide about so-called challenging behavior and communicating discomfort and pain. It's adapted from a talk by Dr. Clarissa Kripke. And I put it here because a lot of times when someone with a communication disability, and especially people with intellectual and developmental disabilities that affect their communication, is in pain and has no good way to communicate that, their communication is interpreted as challenging behavior or acting out. So a non-speaking autistic person with severe migraines ends up getting punished for acting out when what they really need is a neurological exam and probably medication. And it's also why ensuring access to effective communication is so important. It is, of course, easier and quicker for everyone involved if someone can communicate "I have a headache" clearly when they do. People communicate with the tools they have, including behavior. If the only way someone can communicate they're in pain is to scream while clutching parts of their body, that's what they'll do. It's also helpful because, well, there can be a lot of body parts in the same area that can be in pain. If someone is clutching their abdomen while whimpering and rocking, are they having stomach trouble? Do they have cramps? An appendicitis? These are really, really important things to know. Communicating things like how long a symptom has been going on and how much it hurts if they're in pain, are also incredibly important. You should never discount medical issues as a reason people might quote-unquote act out, especially if you are working with someone who has unreliable access to AAC. Changes in behavior can be signs of medical issues or other major issues, like abuse. I'm not saying it's always a medical issue, but when someone has a major behavior change, don't discount medical issues. Here is something to think about, especially if you've been taught to look at so-called challenging behavior through a behaviorist lens. Non-disabled people have challenging behavior around medical issues all the time. Someone is extra irritable and grouchy because they have a stomachache. Someone curls up in a ball, shielding their eyes because they have a bad migraine. Emotional changes related to menstruation is so common that it's a known symptom of premenstrual syndrome. Challenging behavior can absolutely have a medical cause, and disabled people, including AAC users, are no exception to this. There can be a lot of people involved when an AAC user visits a healthcare provider. Here is a hypothetical example of an AAC user going to the doctor. The two main nodes in this chart, the two main people, are obviously the AAC user and the doctor. But those are clearly not the only two people involved. On the AAC user side, you also have their family and friends. You have their DSP, their direct support provider. You have their teachers, if they're a student. You have their physical therapist and their occupational therapist. And you have their SLP. And then on the doctor's side, you also have nurses, physician's assistants, lab technicians, and other providers. You have front office staff, like the receptionists. You have pharmacy staff, both the pharmacists themselves and pharmacy technicians. These are all people who the AAC user could potentially interact with. And so they're all people who should be aware of the accommodations the user needs. After all, what if the doctor sends the AAC user for an MRI and they can't take their device with them? The MRI technician should be aware of what the user needs, and the user should be prepared with a backup method that can go in the MRI. Before we move on, I want to say that this chart is hypothetical. It is obviously ignoring other people who might be involved, like people from insurance companies, people from public health departments, or people who manage medical transit. And not all of those people will interact with the AAC user directly, but it's important for people to plan for what happens if they need to. If someone from the insurance company needs to speak with an AAC user who can't use the phone, how is that going to happen? If someone from the public health department needs to follow up on test results, they need to be aware of how this person communicates to minimize communication breakdowns. If you are supporting an AAC user, you have a role to play in helping them with medical self-advocacy and ensuring equitable access to treatment. We unfortunately tend to think of healthcare as very segmented. Different providers and specialties don't talk to each other. And we also tend to think that unless someone has an actual professional relationship with another healthcare provider, for instance, if you're an SLP working with an AAC user's primary care provider, because the primary care referred that person to you, there's not a whole lot of reason to be involved. But everyone has a role to play. If you're an SLP, for example, you could help a client program phrases into their device that they'll need for an appointment. If you're a DSP, you could help someone by making phone calls on their behalf to set up an appointment if they ask you to. If you're a teacher or paraprofessional, you could work with someone on ways to tell their doctor to stop or slow down if they're too overwhelmed during an exam. If you're a social worker, you could help someone write a letter to all of their doctors explaining their communication needs and how to help them. Remember that most healthcare providers who don't work closely with AAC users don't know much about AAC. It's really easy to forget if you're an AAC user in a field that works with a lot of AAC users, or both. The things that seem obvious to you and may seem obvious to the AAC users you work with are not going to be obvious to other healthcare providers. So any help you can give is worth it. All of this, though, needs to be with the consent of the AAC user. To use myself as an example, I might want help making phone calls or coming up with lists of things to talk about at an appointment, but I don't want someone to actually program my device for me. I also don't want to have to tell my full medical history to anyone who offers to help me. When you're working with an AAC user on preparing for medical appointments, don't overstep your bounds, especially if you don't have access to their medical records. Focus first on the things that would be generally helpful for any medical visit. So, you could help them come up with sentence starters to talk about different symptoms, or brainstorm a list of ways to describe pain with them. You don't need all the details of their medical history. Even if they're preparing for a specific appointment, you don't need to pry. So if you're a DSP helping someone make a phone call and they want to make an appointment with a neuro-ophthalmologist because they've been having blurry vision and headaches, you don't need to ask for every single detail, just enough to make an appointment. So let's stop here and open the chat up for a second. In the Slack channel, it'll be the Track 2 channel. I want you to post answers to this question: what are different ways to say no? Consider that people can say no in polite and impolite ways, and that you can use lots of different words to say no. Okay, great. I'm seeing some great examples. You can keep adding more if you like. Keep this in mind while we talk about safeguarding language, a lot of which is saying no or expressing dislike. It is so important that AAC users always have access to this for healthcare. We are not voiceless. There is no such thing as voiceless, but we are often seen as such by people. And as we've previously discussed, it is so easy for healthcare providers to assume we cannot communicate and treat us as if our choices don't matter. To be quite clear, this leaves us vulnerable to abuse and neglect. The best victim is the person who can't say no, or the person whose no is easy to deliberately misunderstand or ignore. Over the course of the pandemic, there have been horrific stories of largely deaf and disabled people being issued do not resuscitate orders against their wishes because providers said they couldn't communicate. We are already talking about a population whose lives are continuously devalued and who are continually told we are not as worth saving if we get sick. Safeguarding language is a matter of life and death. We need to have access to words like no, stop, don't like that, slow down, listen to me. And these are things that we need access to in general, every day, but they need to be on our medical boards or folders, too. I see a lot of light tech medical boards that have plenty of ways to request things, but very few ways to say no or stop, or ways to communicate you're hurting me. There is a difference between being able to communicate general pain and being able to communicate pain as the result of someone's actions. So now let's talk about making safeguarding language accessible. If you're working with someone who uses a high-tech device, make these words part of their medical board or folder. Or, if you can't do that, make sure these words are easily accessible in a different place or folder, as few taps or clicks as possible. If the device allows it, making a button that automatically speaks something like "please wait for me to finish composing my message" is a really good way to make conversation partners slow down. I also recommend making buttons like no, stop, and slow down auto speak. But again, all of these are recommendations. What you will actually do depends on the person you are working with, or yourself, if you are programming a device for yourself. If you are working with a lighter tech option, I recommend making sure no, stop, slow down, and don't like are all core words somewhere on the board. A letterboard with some core words on it is a great option for some people. If the person has a specific letterboard they usually use, I recommend asking them if there are words they would like to add for their appointment. Even if the person uses a high-tech device, it's important to make sure they have a light-tech backup, no matter what the appointment is for. What if you have someone who uses a device? They go into an appointment because they're having a bad headache, and the doctor orders an MRI immediately because the person might have an aneurysm. Prepare for the unexpected. Prepare for things that are unlikely. Practice using this language beforehand. If you can have a mock appointment or role play, if that's something the person wants, that could be even better. Reassure and keep reassuring. the person that they are allowed to speak up if they feel uncomfortable or just have something to say. It can be really hard in the moment to remember that it is okay to speak up if something is wrong. This is even more relevant for AAC users because of all the steps involved. Or if you're already dealing with a doctor who doesn't know quite how to interact with someone using AAC, there can be this mental roadblock of, oh my God, this is already so awkward. I have to do my best not to make it more awkward. And those are all valid concerns, but they can't get in the way of someone trying to express discomfort. Practice. 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 I want to talk specifically about private issues. This is kind of my wheelhouse, since one of my areas of interest is sexual education and sexual and reproductive health for people with IGD and AAC users. When we talk about private issues, we're talking about things related to sex, gender, and sexuality. We're also talking about mental health and potential substance use. We're also talking about anything that involves undressing or a physical exam. By the way, when I say undressing, I also mean things like changing from clothes into a gown for a procedure. Anything where someone else might see you less than clothed. This is not an exhaustive list. And what one person considers private is not the same as what another considers. If you're supporting an AAC user, defer to their definition of private. If you're supporting someone who does have an appointment concerning private issues, make sure they have safeguarding vocabulary programmed in on their communication method and make sure they know how to use it. This isn't solely about examinations. For instance, think of someone who's meeting with a new psychiatrist and going over their mental health history. The psychiatrist keeps asking questions and the person doesn't know how to or feel comfortable saying I need a break, even though they're close to meltdown. And it keeps building and building and building to the point where they have a meltdown on the bus home from the appointment. When you're thinking of private issues and safeguarding, don't just think of things like preventing physical sexual abuse. Also think of times when you might be in an emotionally or mentally uncomfortable situation and need a break. The next thing to consider is who the person wants in the room with them. If someone is having an exam that requires them to be naked from the waist down, they might not want their usual support person who's never seen them naked before with them. If someone's primary language is ASL, and their usual support person also functions as their interpreter, they might prefer a different interpreter for appointments. A person might want their support person there for part of the appointment, but not for other parts. And someone who usually doesn't have a support person at appointments might want one there for certain private issues. It all depends. But you need to ask. You cannot assume. Okay, the last part of this is privacy concerns with follow-up. Let's say an AAC user goes to their doctor to get an HIV test. And privacy law says that the doctor cannot send the test results to them through an online portal. They can only deliver them in person or over the phone. If the AAC user is someone that usually helps them make phone calls, but doesn't want that person finding out their test results, what are their options? If they have the device, they could use the device to call, or they could use a relay service, or they could find someone they do trust to help them call, or they could schedule a follow-up appointment. The answer is going to depend on a lot of different factors. What matters is that the AAC user feels they can effectively and safely access healthcare. Finally, let's talk about boosting autonomy. This kind of assumes you're in the room as a support person, but some of this is applicable even if you aren't. One of the most important phrases here, one that I want you to commit to memory, is this: they're the patient. Why don't you ask them? If you're a support person for an AAC user, especially if you are not perceptibly disabled yourself, healthcare providers are almost certainly going to default to asking you the questions. Providers love to treat AAC users like we're completely incapable of answering questions for ourselves, as if we do not know our own bodies and minds, as if we are not experts on ourselves. As a support person, you need to redirect. You need to make it clear that you are not the patient, the person you're supporting is. And if you say it enough, providers might just listen. Default to let the AAC user answer questions, but ask them ahead of time what they want you to do. It may be that there are questions that are tedious for them to answer, but easy enough for you to answer. They might want you to answer some questions, or have you keep a hold of documents that are relevant to some of the questions. But if you're unsure what to do, I advise defaulting to letting the AAC user answer and redirecting the provider's questions to them. Your job is not to speak for someone. It's to help them communicate and to support them in other ways if they want. You might be relaying what someone spells on a letterboard or repeating what someone says if they have unclear speech. But that is not speaking for them. You are not their voice. I hear a lot of supporters of AAC users talk about being the AAC user's voice, or, even worse, a voice for the voiceless. AAC users are not voiceless. We may need support communicating, but we are not voiceless. Acting as if we are robs us of our autonomy. It also teaches other speaking people around us that they can do the exact same thing, speak for us, take away our autonomy, treat us as if we are incapable of expressing our concerns. Do not speak for us. Do not allow other speaking people to portray what you do as speaking for us. Be clear on your role. Finally, you almost certainly have more social power than the AAC user or users you support. This is especially true in healthcare appointments, and it's especially true if you're supporting a child, someone with IGD, and or someone with high support needs. Use the social power you have. When I talk about social power, I'm talking about who other people think is in control, who knows more, who's more capable of answering. People are going to assume that's you. People are going to assume you are the person to go to. Correct them of that misconception. Make it very clear that you are not the person who matters here. That's the AAC user, and they're the one who's in control. So, to wrap things up, I want to go through a slide that's based on some of the same concepts I presented on yesterday: autonomy, self-determination, dignity of risk, and harm reduction. A lot of this is too complex for this presentation, but if any of it sounds interesting to you, I encourage you to go back and watch the presentation I did with Cole Sorensen yesterday on these issues. First, autonomy. AAC users are considered our own people. We're not appendages of our parents or supporters. We are our own individual people with hopes, dreams, and goals. Our humanity is not up for a debate. We deserve to be treated as such by healthcare providers. Next, self-determination. We make our own medical decisions whenever possible. If that's not possible, for example, if someone is too young to legally consent to a procedure, we are given as much choice as possible, and the people who are consenting for us defer to us. This also means opposing things like guardianships and encouraging options like supported decision-making instead. Additionally, encouraging AAC users to complete things like an advance directive or a post, so that if we are ever in a situation where we cannot communicate our choices, we have a document outlining them already. Then we get to dignity of risk, which is the idea that people can make choices, even if those choices have negative consequences. AAC users are allowed to make medical or health choices, even if they might be risky. If someone doesn't want to get a yearly physical or go to the dentist for a cleaning, that's their choice. It may not be a good choice, and it may be one that has unpleasant consequences, but they're allowed to make it. I really want to stress that this is not a controversial thing for non-disabled people. Non-disabled people make poor healthcare choices all the time, and even if others around them don't like it, there's not a whole lot they can do. I really want you to ask yourselves, why do poor healthcare choices suddenly become a huge deal when someone is disabled, especially if those choices aren't directly related to their disability? And finally, harm reduction, or ways to make risky activities less risky. AAC users need to have language around choice and refusal, and not just a few pre-programmed choices either. Real choices where someone gets to say, I don't want any of those. We get to say no. We get multiple ways of saying no, and we are taught how to say no in all the ways. Polite or impolite. I said that most AAC users probably have medical trauma. Harm reduction includes things we can do to lessen risk of future medical trauma. So that's all that I have for this. Thank you for coming. I really appreciated it. If you want to, you can reach me at cdenome@gmail.com. I have a blog at Donnie.lgbt as well that I don't update as much as I should. You can ask questions in the chat now. I will try to answer them in the chat after I'm done presenting. If I don't get to yours, Feel free to email me and I will answer as soon as I can. Other than that, thank you so much for coming.
Thank you so much. That was wonderful.